very remote rural hospital, about 12 hours drive from Bangkok. So he is very obsessed or committed to the distribution of human resource. We should all know, I'm sure, that the world is facing several crises. Climate change is one. Pandemic is another. The other one is aging, technology disruption. And the most important one is social inequity, socio-economic inequity. The maldistribution of health professional, not only doctor. Doctor is just a proxy. Is one of the symptoms of the, is one of the expression of the socio-economic inequity. So to solve this maldistribution of health professional, it is very difficult. It's possible, but very challenging without trying to solve the socio-economic inequity, which we should all strive towards that. COVID has given us a very good example and demonstrate to us how socio-economic inequity, which expressed in terms of health inequity, has affected the rich and the poor together. Omicron is a very good example upfront. When South Africa can only cover less than 1/3 or 30% of the population with vaccines, it means that it is possible for a virus to replicate. They spread fast because no immunity, and replicate very fast. When they replicate, there's a chance to mutate. And South Africa also have very high HIV prevalence with low immunity, immunodeficiency diseases. So these all add up to the possibility of new strain of virus, which is more infectious. We don't know about the virulence yet, but it's more infectious. And it disrupts the socio-economic tie and activities. For example, Netherlands has just announced they're going to go towards complete lockdown, and other countries may follow. So this is the world we are now. Unless we solve social and economic inequity, we cannot solve all the crises. Climate change as well. The poor are affected, much more so than the rich. But soon, the rich will not be escaped as well. And health professional maldistribution is one issue up front that we can collectively tackle. We can have at least two options to tackle. One option is to solve the general overall social and economic inequity. The other option is to have specific measures to solve health professional maldistribution. And in my more than 40 years of experience in the health sector and in the life as a citizen, I'm fully convinced that we need both. We cannot go in one direction. One direction will not totally solve the problem. Both options contribute to each other. Measures to achieve more equitable health professional distribution will help reduce social and economic inequity. At the same time, measures to reduce social and economic inequity will also help reduce health professional maldistribution or inequitable distribution. But we should not focus only on geographical distribution. Virod and myself used to work near 10 years or 10 years in rural hospital. We know damn well that why we feel that we are committed to rural hospital, to rural people who are poor, undereducated. But our day-to-day work, more than 50% of the patients we see are those in the urban village around our hospital. Those who are far away, those who are migrants, those who are stateless, they never reach us. So it's not just that you go to that rural hospital and you solve the problem because of the socio-economic disparity. So it's not just geographical, but there are many other maldistribution that we need to solve, including specialization. As you may all know aware, now it is not one doctor per how many people, but it is one ophthalmologist per how many eyes, one ENT for how many ears. That's the problem. You need more and more doctors because of technology improvement, technology development. So I hope that when we discuss this, where is our doctor, how to equitably distribute health professionals, we would not focus only on geographical maldistribution, but specialty distribution among population group, the poor. Even in the capital, those who are poor have difficulties in access to health professionals, which are just in front of their community, but they cannot reach. So it's not just geographical. And I am very happy that Dr. Viro, who is committed, wholeheartedly committed to this issue, lead this side event of the Prince Mahidol Award Conference. And I would like to thank JICA, the GLO+UHC, and all the partners around the table here, around the room, the online room here, that are committed. We don't expect just another talk shop, just another talk show, just another forum to talk, but we must walk the talk at the country level, at the regional level, and at the global level. Once again, thank you so much for you all, for your commitment. With strong commitment, we can move things, even with few people, a few committed people can change the world. Thank you so much. I wish you have a nice and successful side meeting.
Thank you, Dr. Sweet.
Over to you, Dr. Viro.
Thank you, Dr. Sweet, for your enlightening message. I have reviewed Where There Is No Doctor, which was 50 years after the seminal publication. Is a Spanish book try to solve the health problem by the community. And even if you review YouTube today, Where There Is No Doctor, still a major problem in different parts of the world, in South Asia, in Southeast Asia, even in Thailand. 50 years has gone. The book was published in 1973 and was translated into over 70 languages, including Japanese language. And all the health volunteer, the Peace Corps, they use this book to help people. Now, Where There Is No Doctor, it's still a major issue. Now, I'd like to invite Dr. Thinakorn Nori to speak about his Thailand experience on retention of rural doctor. And you have 15 minutes. Over to you. Share your experience with a colleague in the webinar.
Thank you, Chair, and good evening, everyone from Bangkok, Thailand. I have 15 minutes to talk about the topic is retaining rural doctors, lesson from Thailand. My presentation is divided into two parts. The first part is mention about the Thai policy addressing doctor distribution and rural retention. And my second topic allow the health workforce information system in Thailand. I will show you for the overall Thai health system. The Thai health system is pluralistic and public dominated by the Ministry of Public Health. Is the main national health agencies. We have the health facility in all levels, from the provincial level, district level, and sub-district level. We have almost 10,000 health centers all over our countries. In figure one show about the number of beds. You can see the majority of beds are in public sectors. And the figure two for the service utilization allowed us 75% occur in the public sector. I moved to the policy intervention to addressing distribution and rural retention for doctors. Thailand has many strategies to tackle, which doctors which said the geographical inequity. For the educational intervention, we have the strategy to establish the promote local health professional schools. For the new medical school and new nursing school, we urge them to locate outside Bangkok. You can see that 14 medical schools are located outside Bangkok and allow the 65 nursing school located outside Bangkok. For the regulatory interventions, we have the educational subsidy for the health workforce training. For doctor, the Thai government subsidize allowed 60,000 US dollar per one medical students. And for nurses, the Thai government subsidize allowed 4,000 US dollar per one nurses students. Combined with the educational subsidies, we have the compulsory public services policy. That means all the doctors and dentists, after they graduate, they have to work in the public sector for 3 years at least. If those break this contract, they have to pay fine. The fine is allowed 13,000 US dollar for the normal track for doctor and the CPET program. I will talk about the CPET program later. And we have the special program we call the ODOT program. If they breach this contract, they have to fine 67,000 US dollar per student. For the financial incentive, the Ministry of Public Health, we have the special financial incentive to promote, to urge the doctor to work in the rural area. We have in 1995, we have the non-private practice allowance. This allowance pay for the doctor and dentists who work in the rural area. In the public sector only, the government paid allowed 250 US dollar per month add up to their salaries. In 1997, we launched the hardship allowance to 3 levels: level 1, level 2, level 3. Level 3 is very remote area. For the doctor who work in the mountainous area for the islands, they have to the government pay more allowance to promote them to work there. In 2005, we have the special allowance for doctors who work in the rural area more than 3 years. We add up allowed 125 US dollar per month. And 2016, we readjust the hardship allowance again. For in average income for the first year doctor who work in the rural area, they will get the salary around the 2,000 to 2,600 US dollar per month. It's quite a lot. So this high payment make a negative impact to a small hospital. They have a financial problem to pay this salary to the doctors. For personal and promote, Thailand, we have the award for doctors, nurses, and pharmacists and other cadres who work in the rural area and contributed to the communities. We also have the policy to improve the living condition in the hospital, in a very, very remote hospital. We have the well-equipped infrastructure with adequate medical supply. We provide good logistic support and housing for the staff to work in the rural area. I would like to introduce successful interventions that I said before, the CPERT program. The full name is the Collaborative Project for the rural doctors. Thailand started rural recruitment policy since 1974, very, very long time ago. In 1995, we start this program, the CPERT program. The CPERT program is the collaboration between the medical school under the Ministry of Education and the regional hospital under the Ministry of Public Health. At first, in 1995, we start with only 8 medical students in Khon Kaen Hospital in the northeastern part of Thailand. Currently, this program, we get the annually student allowed 1,200 medical students per year, accounted allowed 36% of total production capacity each year. Currently, we have the 19 medical schools join this program, and we have the 39 medical education center under Ministry of Public Health to join this program. This slide shows the collaboration between this program between the Ministry of Education and Ministry of Public Health. You can see that the medical school and the medical education center are all around the countries. For the CPERT program concept, we apply the concept of the rural recruitment, local training, and hometown placement. For rural recruitment, we recruit the students from the rural area at the provincial pool. We separate not the general examination. We recruit them from the provincial pool. After we get these students, we train them in the local areas. For the first 3 years, for the preclinical year, we train them in the medical school and the Ministry of Education. The second 3 years, for the clinical year, we train these students in the regional hospital that locate all over the countries. After these students in this program graduate, they have to go back to their hometown and work in their hometown at least 3 years. We have the community engagement. For the curriculum, we focus on the community engagement. We have to train the students to work in the rural area. Nowadays, CPERT are the backbone of the rural doctor in Thailand. This slide, you will see that the increasing number of the CPERT students each year. We have a study to compare the duration of the CPERT student and the non-CPERT program work in the rural area. This study showed that this is the survival curve. This study showed that the students from the CPERT program, that we recruit them to the rural area, we train them in the local hospital, and we place them at their hometown, tend to stay longer than the non-CPERT program. The result of the CPERT program. The first in the 1995 till the 2017 is this data. The admission rate of the student only 0.4% is very, very small. Many people say, what about the quality of this student in this program? We found that almost of them, 99.6% passing the licensing examination. And a number of doctors who work in the rural area, allowed 50% now are graduate from this program. Result from the many strategy, we have more doctor, better distribution. In 2000, you will see first graph. In 2000, we have the one doctor to 2,400 populations. In 2015, the city and better. You will see the red in the northeastern part in Thailand. That's it, very, very rural and remote. Become into the yellow and green. It's better. Good distribution. In summarize the condition for the success, the bundle or the package of policy is very important. The combination of national strategy in the package is very important. This comprehensive strategy should be coordinated by the Unified Health Workforce Policy Mechanism. And the last one, I would like to concur Dr. Suvit's idea is the more equitable socio-economic development is the key factor for sustainable success in the social equity. This needs a strong political leadership and also social support. This is very, very important. I will go to the second part, the Health Workforce Information System in Thailand. In Thailand, the Health Workforce Information System comes to three main sources. The first one is the registration by the Health Professional Council. Currently, we have the 8th Health Professional Council in Thailand. The second one from the facility-based registration. The facility-based registration we form the public sector from the Ministry of Public Health, Ministry of Defense, and University Hospital, and then Ministry of Education, and from the private sector. The third source from the survey. Thailand, we have the regular survey by the Thai National Statistical Office, or NHSO. We have the population census every 3 years. In the census, the questionnaire asks, what are their career? So we have the individual health professions, but every 10 years. The NHSO have the 5 years survey for the private hospital survey. From this survey, we just got the aggregate numbers that this private hospital have 20 doctors, 40 nurses, something like this. And we have the ad hoc survey. I will go to the registry in the Health Professional Council. The advantage of this information is almost 100% coverage. This is the if those want to practice in the labor market, they have to get the licensing examination and register to the Health Professional Council, everyone. This is the individual information. We have the name, surname, birth date, and national identification number and specialty. The limitation of the registry in the Health Professional Council is no update. For example, for the Thai Medical Council, after they graduate, they register to the council once, and the lifelong registration. But in some professional, this periodic updates. For nurses, for dentists, and for pharmacists, they have the re-licensing system every 5 years to update this data. For the registry in the health facility, the advantage is a high coverage, particularly in the public sectors. in this data, we have the subnational data. For the individual information, they have name, surname, birth date, national identification number, and they have their current workplace. For the limitation of this data, we have the limit information in the private sector, very, very limited. And we have the incomplete information in their specialty in some facility. Ministry of Public Health have the official national health workforce information. Ministry of Public Health Thailand conduct health workforce survey in all facilities, but for the voluntary survey every year. From the survey, 100% coverage in the health facility under the Ministry of Public Health, and the high correlate more than 90% in the other public health facility from the hospital, university, and Ministry of Defense, but very, very under-report from the private hospital and private clinics, particularly in Bangkok. For the movement in Thailand, 2 years ago in 2019, we established a national health workforce core indicators. From the committee, we agree the 17 indicators derived from the National Health Workforce Account. These are indicators including the education indicators and the labor market indicators. This year, we try to develop a clean minimal data set which derived from the WHO recommendation among professional councils. Next year, the Ministry of Health plan to develop an electronic platform for data sharing between the Ministry of Health, and we have the 4 pilot professional council. We have the Physical Therapist Council, Medical Laboratory Technician Council, and Thai Regional Medicine Council, and the Royal College of Family Medicine to share the information in the online platform, electronic platform. And next, we try to expand to all professional councils. Our last slide for the challenges. We have the difficulty in accessing the health workforce data in the private sector. We have the problem to identify the part-time practicing. The system have to change from the 8 count to the full-time equivalent system. We face the new practicing model, a group practice, a gig economy that for doctor, they work in many hospital or many clinics. We have to identify the inactive health workforce. This group is good for the search capacity in emergency situation. Thank you very much.
Thank you very much, Dr. Thinakorn, for your useful, inspiring message how Thailand has been implementing a number of measures to ensure to increase production as well as retention through multiple brand intervention. I now like to invite the next speaker to share her experience from Lao PDR, Dr. Manipet Pimasan. She is a technical staff, Department of Health Personnel, MOH in Lao PDR, Vientiane. She will give a presentation on the country effort to address HRH distribution in Lao PDR. You have the floor, Dr. Manipet. Sabaydi.
Sabaydi. Yeah, wait a moment, please. Can you see my slides of presentation?
Yes, very clear. You go ahead. Yes.
Okay, thank you to share. Good evening, ladies and gentlemen. Today, I'm really happy to present you on the attempts to address the HRH distribution of the Lao PDR in 2020-21. This is my outline of presentation. I divided in 3 parts. The first is I will talk about the HIS situation and challenges. Second is I will talk the intervention to improve the distribution of health workers. And the last, the next step that we want to do. The health worker in Lao PDR was gradually increasing from 2005 to 2015, as you can see in the figure. However, from 2016 until now, we found that the health worker per 1,000 population, or the proportion of the health worker tend to decrease, and the qualify of medical health worker. If we say medical health worker include doctor, nurse, and midwife, have only 1.4 per 1,000 population. So if we compare with the recommendation of WHO to meet the SDG by 2030, we have to have 4.45 physician, nurses, and midwives per 1,000 population, but Laos still have only 1.4. So it's still so far to achieve that. And this policy brief also stressed that the maldistribution of health workers results in poor availability of health services and negative health outcomes, particularly in rural and remote areas. And this shows the proportion of doctors, nurses in the region. We found that Lao PDR still have low proportion of medical doctors in the region. And now you can see in the map, there were the different, the distribution of the medical doctor, nurses, and midwives between provinces. And if we look in the district level, we talk only the clinical health worker who have the clinical skill, including the specialist, medical doctor, medical assistant, primary healthcare. So we found that there are different distribution in between district level also. And if we look in the health center level, there are almost 25% in of health center have no clinical health worker. And the existing health center who have the health workers, the majority is the middle level. This slide show the first graph show that the majority of the health workers are located in rural area. However, if we see in the health profession, like a medical doctor, we found that the proportion of medical doctors deployed in urban area more than rural area. And this figure show that in 10 years, Lao PDR will have the shortage of the health worker, especially the specialists in any discipline. And this figure show the production and the recruitment in public sector. We found that the production is more than the quota or the recruitment of the government. So the summary of the Lao HIS challenges, including the limitation of civil servant quota from the government, because now Lao government have the reduction policy. So this policy affects all ministry. The shortage and maldistribution of health workers with the higher education at provincial and this level, particularly medical doctors. Improper skill mix of health professions at all levels. The new medical graduates do not have adequate clinical knowledge and skill to work independently in rural district or rural area. And local health professional education institutes lack resources and capabilities. And the last, low productivity and motivation of staff in rural area especially. So Based on these challenges, the Lao government as well as Ministry of Health make an effort to address the distribution of health workers in Lao PDR. So there are several interventions were developed and issued, including in 2001, the Residency Specialist Fund, or we call Specialist Fund in Laos, programs for health staff was developed. In 2005, the compulsory service in rural area of new government staffs. In 2007 and 2008, the health personnel information management system was developed to analyze the HRS situation and to know the need and the gaps. And the 30% of admission for the upgrading health staff. In 2010, the human resource for health development strategy and HRS projection tool, financial for civil servants to work in rural areas, and 15% of number of student admission from rural area were developed and issued. And in 2011, there was the productivity tool that we can know and to have better allocation of the health worker and focus more the high utilization rate. Compulsory service of newly graduates allocation in rural area policy. This policy is impact from the HRS development strategy from 2010 to 2020. And this year we have we got the quota from the government, 4,000 quota. So this impact from our strategy. And from 2015 to 2018, there were many policies, including the village health workers allocation, midwives allocation in health center, fellowship program, or we call specialist too, health workforce development plans in 18 provinces, roadmap for attainment of the HRS reform strategy by 2030, reward the best health center. And from 2019 to 2020, there were many policies, including staff allocation to health center with less than 3 staffs, clinical health workers allocation in health center, and the medical civil servant degree that include the upgrading the salary of medical doctor, and also we provide the incentive to health worker from the technical revenue. So now let me move to share the experience for our intervention. The first is the compulsory of the new graduates allocated in rural area policy. This policy was endorsed in 2012, and from 2013 to 2014, the new graduates of MD, medical doctor, nurse, midwife were allocated in rural facilities, and the civil servant quota was provided for them. In 2021, we monitor the deployed graduates from 2013 to 2014 in the health facility. We found that more than half, around 67% still retained in the same health facility. So why we show the picture of the class? This is the depend on the point of view of the people. If we see the empty class, we will think that, oh, this is not working. But if we see the water in the class parts, we can see that this policy is still working, still improve our distribution. And the second experience I want to share the clinical health worker allocation in health center policy. This policy was endorsed in 2019 under the Health and Nutrition Services Access, or we call HANSA project, supported by World Bank. And there are set up indicator each year to reduce the number of health centers without the clinical health workers. And there are regularly monitoring, supportive supervision, and regularly providing the budget. And the important point is their involvement of the provincial and district level. So this table shows that after implementation of the policy, we found that the number of health centers without the clinical health workers was reduced. And the last experience that I want to share is the reward the best health center. This policy was adopted 2018, supported by Lao government budget. The reward the best health center committee was set up. The staffing norm and productivity tool was used to screen the high utilization rate of health center. Questionnaires and checklists were developed to check the high utilization rate of health center on the site visits. And there are several meetings was conducted to select the best health center. And we provide the reward certificates and financial incentive to the best health center in the important events of the Ministry of Health, including the annual HIS conference, the Ministry of Health conference. So to ensure allocated the health workforce in the health facility, we have some commitments from the AAAH conference in Vietnam in 2018. So the top priority to implement is the 1.1 accreditation mechanism for the health training institutions and health workforce. So this is our roadmap that we made at that time. So we have some progress of the licensing and registration for health workforce, the TOR of Health Professional Council, the Health Professional Council Committee, and some actions were developed. The piloting the national examination for new graduates of MD, dentist, nurse, midwife in 2019. So this we just piloting. And in 2020, we conduct the national examination, including the MCQ and OSCE for new graduates of MD, dentist, nurse, midwife. And we implement the licensing and registration for the health worker, as I said, medical doctor, dentist, nurse, midwife, who graduated before 2020. This is, they will not have an examination. So we have many challenges of licensing and registration system in Lao PDR, including the understanding of importance of accreditation. How professional licensing registration system just started functioning, but still limited. There are some limitation of licensing targets, as the target to meet the Asian MRA criteria. We still have only 25%. That's the target. So we still have left 75%, not the target of the licensing, including the assistance, sources, the human resource, information, the tools, logistic capacity and competency of health professional council staff, and commitment, multi-sectoral coordination. For the last slide that I want to share is the next step, what we want to do. First, continue the interventions to improve the HIS distribution and decide the new interventions, including the sub-legal of medical CV degree should be endorsed, including contracted staff, performance, technical position degree should be endorsed. And HIS development strategy 2021 to 2030 should be endorsed and reward the best health center and individual. Determine the job description of health workers in the health facility. And the second is strengthen the health institutions, including infrastructure, faculty development, and quality assurance. The third is strengthen the licensing and registration to have more functioning. And the last is the strengthen the health information system and health human resource for health monitoring and evaluation system. Thank you very much for your attention.
ขอบใจหลายๆ Dr. Mani Phet for your comprehensive graduate progress in multi-dimension of health workforce accreditation training more and put them into the rural area, including compulsory services. Congratulations for consistent progress and you identify your challenges. Thank you so much and ขอบใจหลายๆ I invite Kusongpu, Mr. Tenzin Chopel. He will talk about Bhutan service and health workforce standard as a mean for equitable distribution of health workforce in Bhutan. Tenzin is the Director of the Directorate Service, MOPH, Royal Government of Bhutan. You have the floor, sir. We have 50 minutes.
Thank you, Dr. Biroj, and a very good evening from Bhutan. Am I audible?
Yes, you are very clear.
Thank you.
Go ahead.
Thank you. I would like to first of all thank the organizers of this side event for giving me this opportunity to make a presentation on behalf of the Ministry of Health of Bhutan. Perhaps I'm the only participants without a clinical background here. Hopefully I can do justice to the presentation today.
Doesn't matter.
When I started preparing for this presentation, I was reminded of a quote by Martin Luther King, who once said, I quote, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhuman," unquote. These often quoted words offer moral sustenance to many people and health workers like us who are working towards health equity. And today's topic on this PMAC site event, where is our doctor measures for the future distribution of health workforce, reinforces our collective commitment to this moral sustenance. What I would like to present today—
Excuse me, Dr. Mr. Tenzin, I'm sorry. We are seeing your presenter's view. Could you click display settings? Yes. And could you click duplicate slideshow, please? Thank you very much. Yes, now we can see your slide. Yes.
Okay. Sorry, I'm having some issues here.
I'm sorry.
It still does not work, your screen.
Sorry.
It's okay now.
I think it's still—
Yes,
is it okay now?
Okay. Yes, it's okay now. Thank you.
Now.
Okay, so I'm having some issue with my laptop. Just hold on, please. Okay, so what I would like to present to you today is health service and HRH standards as a means to equitable distribution of health workforce in Bhutan. We know that a strong health workforce is widely recognized as a prerequisite for healthcare and a crucial determinant of health system performance. So with this background, let me move to my presentation. Although there are lots of, in the outline, you may see several topics, but I will try to finish it in time. So I will basically run through some of the key indicators and vital statistics of health system in Bhutan. And also I'll touch briefly upon why the rationale of coming up with these standards, and also some of the guiding approaches to these standards. Then I'll give you an overview of how the service standards as well as the HRS standards look like in our system of health services. And then we will also, I will touch upon some of the gaps insofar as the health human resource is concerned. And then finally, I will wrap up with the implementation modality of these standards. This is a map showing distribution of health centers by region. The green one is to the western, it's western region, the gray one in the central region, and the blue one in the eastern region. If you look at it in terms of health infrastructure, we have the distribution is quite okay across the country. We have also depicted here the outreach clinic, the hospitals, the primary healthcare centers, the district hospital, the regional referral hospitals, and the national referral hospital. This one is, I just wanted to show that when we have gynecologists in the region, for instance, if you look at places like Thimphu, and then to the south center, Sarpang, and then towards the east, there's some district called Mongar. These are the three places where we have the regional referral hospitals. And therefore, if you look at the institutional birthing, you will see the numbers very high. Now, the ministry is currently in the process of improving the clinical governance by way of providing specialist services throughout the districts. But if you look at this map, the challenge is that 67% of our population still are not able to access the specialist services within their districts, and therefore they have to go to the so-called regional referral hospitals or the cluster hospitals, which I will talk about it later. This shows the availability of doctors and nurses across the Southeast Asia region. And if you look at Bhutan, we are still below the red line. But the good news is we are improving the density of doctors, nurses, and midwives as we progress. So perhaps we will be reaching the global target of 45 to 5 per 10,000 in maybe 5 to 6 years. These are some of the statistics that I was talking about. Our population is very small. If you look at it, we are just under 1 million. But the western region, where the capital city is, we have more than half the population there. So accordingly, if you look at the admissions of patients, outpatients, you will see a big difference between the regions. These are some of the statistics that I thought I will share. This is the distribution of health facilities. As I mentioned earlier, we have 3 regional hospitals, and then we have the so-called 60-bedded, 40-bedded, 20-bedded, 10-bedded. Some of you must be thinking that why smaller number of bedded hospitals, but these are catering to a smaller population in our districts. Then in terms of human resource distribution, again, region-wise, if you look at it, the number of specialists in the Western region is high because the National Referral Hospital, where almost all the specialists and subspecialists are there. Therefore, it's skewed towards the Western region. We are still, as I will discuss later during the gap analysis, we are still short of doctors and nurses. Now, coming to the crux of the presentation, why we are developing this service and HR standard. It is basically to consider equity distribution of services along with availability, accessibility, acceptability, and quality of human resource HR across the country. It is also the need to reform the governance structure of regional and district health services with functional structures to provide quality clinical services with a clear TOR for all the levels of health facilities. The other reason is to provide integrated service, people-centered services at the community level, and also finally to provide on-site services or through empaneling of service and HR from higher centers and with strengthened care coordination and accountability. Some of the guiding approaches and principles to these standards. We would like to ensure that all the generalized specialized services are available across the region, as you have seen in the earlier slide where some of the about 67% of the population are not availing the specialized services within their districts. The 2 regional referral centers, that is the Eastern and the Central, because the Western is the National Referral Hospital as well, will have all the general specialist services along with diagnostic and lab facilities. The National Referral Hospital will function both as Western Regional Hospital and also as a National Referral Hospital with all subspecialty services. The ministry also intends to strengthen both the national as well as regional referral hospital in terms of HR and governance system, especially for accountability of clinical services to the whole of region. The regional referral hospital, as of now, are headed by a medical superintendent, but we would like to improve their level to medical director, who will oversee and provide stewardship for all clinical and public health services for the region. Likewise, later I will talk about the service standards both for regional as well as national hospitals. There is something called cluster hospital, which will be providing basic specialist services, especially in the field of gynae, pediatric surgery, orthopedic, and so on and so forth. And this cluster hospital will at least be a 60-bedded hospital. The regional referral hospital will be also the hub for biomedical services, quality, clinical auditing, epidemiology and research, and so on and so forth. And they will also house the regional medical supply for buffer stock like medicine and medical supplies. Now, when it comes to the primary health centers, doctors will be posted there depending upon the need. In a very progressive manner. As I was mentioning, we are still short of GDMOs, the doctors. And we are also planning to empanel under the care coordination team if permanent posting may not be efficient. Then I will skip this. Now, coming to the health service standards. I have several slides, but I would like to briefly touch upon all these slides so that we have a general understanding of what it is all about. So like any other health system, we have this three-tiered health service, the primary healthcare, the secondary, and the tertiary healthcare. Under the primary healthcare, we have the outreach clinics and the primary health centers. Under the secondary health care, we have the district hospitals, which are 10-bedded, 20 or 40-bedded. And under the tertiary healthcare, we have the 60-bedded cluster hospitals, the regional referral, and the national referral hospital. So if you look at what are the core services that we are providing at the outreach clinic level, these are immunization services, and we also do the homebound visits for palliative care and care coordination and medicine refill. So there will be no empaneling of services at the ORC. At the PHC level, the primary health care, we have the on-site services, we have the outpatient services, observation, nursing, and all this. I do not want to for the I think I'll be running out of time if I read all this, but if you look at the empanel services, we will be providing from the district hospital lab services, ultrasound services, X-ray services, and other care coordination services. At the 10-bedded hospitals, these are the sort of core on-site services that we will be providing. And the specialized services will be empaneled by regularly visiting the hospitals from the regional referral hospital or the cluster hospital. So these are the sort of basic minimum services that will be provided from the 10-bedded hospitals. Now, I think similarly for the 20 and 40-bedded hospitals, we will be providing this. And similarly, all specialized services empaneled will be by visiting the specialists from the regional referral hospital or the cluster center hospital. So at the tertiary level, we have these three hospitals, the 60-bedded cluster hospital, and then we have the regional referral hospitals. So at the regional referral hospital, all the services at the 60-bedded hospital plus the other services. And these services will be empaneled with subspecialty services from the national referral hospital, perhaps at the frequency of 3 monthly or once in a dedicated period of one to 2 weeks. So for the national referral, all the services at subspecialty level will be provided. For empaneling services, collaborative and twinning services with external center of excellence will be provided. Experts from other countries visiting periodically for training and patient care services will be done at the national referral hospital. So corresponding to the service standard, we have also developed this HR standards, which estimates HR requirement according to the population to be served. Of course, some countries determine a team of family care providers and led by a family doctors for every 200 to 300 families, but others do consider a family doctor and team for every 3,000 to 5,000 people. So here we have estimated our HR needs as per the health service utilization prediction model based on population to determine the HR needs and requirement of hospital beds. And also we have based on demands and based on health systems as decided by experts using established criteria and service standards. So these are some of the general criteria that we have used. Now, these are based on the facility, like the outreach clinic, the primary healthcare centers, the hospital, district hospital, the urban health centers, the 20-bedded hospitals, the 40-bedded hospitals, 60-bedded hospitals, regional and referral. So accordingly, we have developed the minimum HR requirement for each of these health facilities as well as what are the empaneled services that will be required to deliver services from each of these facilities. I do not want to go into the details of all the minimum HR requirement. I think almost all are sort of familiar with this whatever I have shown on the slide. Now, these are some of the standards that we have maintained. For instance, in general ward, these are the nursing care standard. For general ward, we have to 1:6 in cabin, 1:1 for onco, 1:2 for birthing, 3:1 for pre-anesthetic, and so on and so forth. This is just a general nursing care standard that we have developed. And these are some of the gap that we need, the gap as per the new standards that we have developed. So if you look at the red ones at the end, we have a long way to go as well. This is my second last slide, I guess. So in the implementation modality, all allocated HR numbers for each health facility are based on the overall standards that I presented. And these standards may be recalibrated on a periodic basis based on findings of joint service and HR standard monitoring team. And based on these findings, health facilities may be expanded, strengthened, or consolidated. And these facilities can also avail HR and services through the empanel system so that community get the services and care that they live within their proximity. So while we have this implementation modality, ultimately it will depend on the deployment criteria. These are the 5 criteria that we have set. For example, the first thing we have to look is the strategic locations of the health facility and proximity of other health facilities from where our people can avail the health services. We are also looking at the catchment population and its composition. And we are also looking at morbidity and mortality pattern. And also concurrently, we will be conducting situational assessment of service standards implementation. As we implement the service standards, we will be continuously monitoring. And also other factors such as equity, poverty index, migration, and demographic movement of that particular geographical location will be taken into consideration. Of course, I made this presentation a little bit, I thought within 15 minutes we could cover much more, but since I have run out of time, and with this, thank you and Tashidele.
Tashidele, thank you so much, Dr. Tenzin, for your experience in setting 2 standard, HR standard and service standard by level of healthcare from local unto national referral hospitals. I now invite Japan experience by Dr. Takuma Kato, the Chief Advisor of GLO+UHC Phase 2. He was the former Director of Office of Physician Training, Planning and Coordination, MOPH, Labor and Welfare in Japan. He will talk about the current measure to improve doctor distribution based on the registry. Over to you, Dr. Kato.
Thank you, Chairs, and thank you so much for this opportunity. I'm Kato, Chief Advisor of the JICA GLO+UHC project. And previously, I was a responsible person in distribution of physician in Ministry of Health, Labor and Welfare, Japan. So today, I'd like to share our current measures to improve the distribution based on the registry with focus on the physician in Japan. Firstly, let me introduce some features of the Japan's healthcare system. So Japanese population is now decreasing since 2008. About 70 to 80% of the health facility are private, and almost all the population is under the public health insurance with single fee schedule. Now, Japan has 47 prefectures, and due to the current decentralization, the governor has more responsibility to deliver health services. So they need to consider the allocation of health facilities and health workforce. As this chart at the bottom shows, these health professionals are increasing, but when it comes to the distribution of the physician is main issue in Japan. Here is today's contents. Firstly, I'd like to show some history on the policy on health workforce. Secondly, I'll show you the outline and some background. Then thirdly, this is the main point today, but I'll show you the registry system in Japan. Then based on the registry system, I'll show you the current measures and its PDHCA cycle, and finally the shared current challenges and our lesson learned. From the viewpoint of the finance, Japan reached the UHC in 1961 by the expansion of the national health insurance to the uninsured people, including the farmers and the self-employed person. However, the access to the healthcare was still limited at the time. So government tried to improve the distribution of physicians through establishment of the JICA University, which is willing to produce rural doctors, and the introduction of the one prefecture, one medical school policies. However, unfortunately, many medical students come from the urban prefectures, and they study in rural prefectures, and then they go back to the urban areas after their graduation. So its effect was limited. So this slide shows the current outline of the density and supply of the physicians. The upper left side graph shows the number and the density of the physicians, including the projection until 2040. The number of the physicians is continuously increasing, and total population in Japan is now decreasing. So the density of physicians to the population is going up. However, even after the Japan reaches a high density of the physician, the maldistribution of the physician has never been solved. The government continued to set the medical student quota to its maximum to reduce the area of the physician shortage based on the strong requests from the governors. Governors are the responsible person who provide health services in each prefecture, so they ask for the more budget and physician for their own prefectures. So we need to prepare some logical theories to use the limited budget to prefecture, which should be the prioritized. I'd like to share the outline of our registry system for the physician in Japan. So dentists and pharmacists also have the similar system since 1948. Like other countries, basic principles about health workforce are professional autonomy, but the government has a responsibility to deliver the adequate health services. So the government manages its registry system based on the registration after national exam and census survey every 2 years. Currently, we started to integrate the information of the postgraduate training and specialty program. We are arranging the items of the census of analysis of distribution. So we currently added some specialty and also the university and also the birthplace as well. In Japan, we collect the census questionnaire through health facility. The prefecture strongly supervise the health facility so that we could keep more than the 95% response rate so far. To keep the high response rates, the incentive for the physician is also quite important. The physician responds to the follow-up census every 2 years, so that they could be on the list of the physician of the ministry. The general public can confirm whether the person has a national license of the physician or not, based on the list through the website to detect fake doctors. Sometimes the fake doctors are emerging and becomes challenges in some areas. So this registration system are required. So this is a mapping of our measures to improve the distribution of the physicians. We have 3 points to be intervened: enrollment of the medical student, and entry to the postgraduate training and specialty training. So regarding number 1, regional quota with scholarship, which imposes compulsory work in the specific prefecture for 9 years, and number 3 and number 4, each capping or the ceiling the capacity of the trainees. We decide there the volume of the quota or the capacity in each prefecture based on the data from the registry. This is the PDCA cycle of the measure to improve the distribution. At each step, we utilize the registry or some tools based on the registry to make the measures evidence-based. From now, I'll show some detail of these tools. At first, distribution indicators. As I mentioned already, the number of the physicians are political issues at the prefecture level. And every prefecture insists that they need more physicians, including even Tokyo. They appeal that there's a reason of the wanting more physicians, so the government need to set more the appropriate and reasonable indicator rather than density. So technically, we calculate the distribution indicator based on the density from the registry from every 2 years the census here. And then we added the flow of the population. And also we consider the population structure and also the physician's basic information, because it's related to the physician's working hours. Then distribution indicator can show a more realistic shortage or surplus in each prefecture. This is the concept of the distribution indicator. So this is the actual figure of the distribution indicator. So you can see the trend of the distribution indicator, and you can find the Western Japan seems to have the more access to the healthcare. And the difference of the distribution indicator between the ranking number 1 Tokyo and also the last one is Niigata, they have the almost double. Although they pay the premium at the almost same level. For the planning and implementations, we can divide all the prefecture into 3 groups and utilize the distribution indicators. The table shows the projected shortage and surplus of physicians in each prefecture in 2036. The numbers are calculated by the required number of physicians based on the expected demographic change and estimated number of the physicians based on the current supply level. Prefectures in blue box are predicted to face physicians shortage even in the 2036. So government need to prioritize such prefectures when they plan the measures. As I've already shown, we implement mainly 4 types of the measures. Number 1 and number 2 targets the enrollment of the medical student. So the effect will appear at least 6 years later. So the government use estimated number of the physicians shortage in the future. the government allocates a more regional quota with scholarship to the expected shortage prefecture in the future, like Niigata. In contrast, number 3 and number 4 are capping or the ceiling the capacity of the trainees for postgraduate training or the specialty program. So these measures relatively lead to the quick effect. So the ministry uses the current distribution indicator to allocate the capacity to each prefecture. As Dr. Sweet mentions, maldistribution in the specialty is also the big problem in Japan. Ministry has set the ceiling number to the specific specialty program in specific prefecture, which is projected to be the relatively surplus in 2024 or the 2036. For example, in Tokyo, only 398 physicians can enter the specialty program of the internal medicine, and dermatologist only 54. The right number shows the capacity of the special program, in which half of the program will be conducted in the prefecture, which is suffering from the severe shortage. As for monitoring, the ministry is using the registry to analyze the measures. For example, regional quota with scholarship started in 2008. Its effects can be seen from the 2014, so 6 years after the launch, because it takes us at least 6 years for the medical student to graduate. So since 2014, the number of the prefecture with low distribution indicators of physicians has increased largely than other prefectures. So this one also shows the analysis of the capping capacity of the postgraduate training. So government introduced the postgraduate training course as a duty for the physician in 2004. Just after the introductions, more newly graduated physicians moved from the rural area to the urban area. Around 2010, we introduced a capping capacity to each prefecture, and currently we strengthen the capping based on the registry data. Now the ministry is mainly following up the trend of the urban 6 prefectures. I cannot share everything, but as I explained so far, each step of the PDCA cycle requires the data from the registry system to make the measures evidence-based. So this is the current challenge. So digitalized census of the health workforce is one of the big current issues for our ministry. And in each prefecture, more physicians working in the prefecture capital. So each prefecture needs to improve the distribution in each prefecture inside as well. So moreover, we need to consider the quality of the physician in terms of the competency to manage the rural or the community health. Actually, we started to the enrichment program for the general physician in 6 selected universities from the 2020. So this is a lesson learned from the Japan's case. So improving the health workforce distribution is one of the continuous challenges even after the health system is well developed. The registry system enabled to take evidence-based measures effectively at every step of the PDCA cycle. In particular, the projection of the health workforce using the registry is required to reduce the future gap of the distribution. To develop the effective registry system and measures, consensus building with stakeholder and arrangement of the incentive to encourage the physician to respond to the census are crucial. So thank you so much for your listening. If you want to improve the distribution of the health workforce, our project is always ready to collaborate with you. So please contact us. Sorry for long presentation. Thank you.
Thank you. Thank you very much for your very insightful information on doctor registry and physician, and I hope other professionals as well, pharmacists and dentists. That is one of the key tools for equalization of the workforce density across prefecture, as well as many other complementary intervention. I'd like now to invite discussant to give their comments on the 4-country presentation. I would like to invite Dr. Anna, Deputy Director of Management of International Health Workforce, Human Resource for Health Development and Empowerment Agency of the MOPH in Indonesia. You have the floor, Dr. Anna.
Thank you, Dr. Firot, and good evening, everyone. As Dr. Firot introduced me, my name is Anna Kurniati from the Ministry of Health, Indonesia. And I would like to thank to JICA for inviting me to join this important event. First of all, allow me to congratulate all speakers for sharing best practices in improving the distribution of medical doctors in your country. As I also learned from the WHO previously stated that approximately 4.45 health workers, including doctors, nurses, and midwives per 1,000 population are required to achieve the median level of attainment for selected SDG targets. So I think this discussion is really important for us to learn that every country should have achieved this minimum density threshold. And as also mentioned by Dr. Sweet at the very beginning of this event, the increased demand of quality healthcare services and also the advancements of medical technology certainly would require more educated number of doctors. And from 4 speakers, we also learned that the equity distribution of doctors remain one of the biggest challenges in providing quality of health services. We note that maldistribution, especially between urban and rural areas, still exists in Thailand, Bhutan, Laos, PDR, and also in Japan. And to improve the availability and retention of doctors in rural areas for more equitable distribution of health workers, extensive interventions have been implemented. And I noted that all 4 countries in this session have made consistent progress with the distribution of health workers with various interventions implemented, including scholarship and education subsidy for health workers, compulsory services, and financial incentives. For example, from Thailand, offers competitive payment even for the first-year doctors. I learned about 2,000 up to more than 2,500 per month. That's quite high. And also conducting some rural recruitment, local training, and also deployment at the hometown. And I also learned from Laos PDR, applied some residencies for specialists, improve HRH information, rural recruitment for medical student admission, and also apply staffing norms and productivity tools, and also rural deployment of health workers. And I also learned from Bhutan to implement staffing norms for health services to ensure the sufficient health workers to be met by health facilities. So there is some kind of standardized services to be implemented. And I also learned from Japan that apply quota allocation for medical students based on the prefecture to maintain the sufficient number of medical doctors. And based on the speakers, we can understand that human resources is very dynamic, and therefore monitoring the availability and also distribution of health workers should be conducted on regular basis. It is interesting that, for example, Thailand and Japan use national survey to understand the most current situation of health workers, and especially for medical doctors. And also medical council already established, including in Lao PDR with the primary role in maintaining the registration of medical doctors, not only to ensure the competency of medical doctors, but also to keep the registration as well. I think from the best practices presented by 4 speakers, and also some challenges that remains in improving the distribution of health workers. In Indonesia, we face more or less the same situation. We still face some challenges in having sufficient and also well distribution of medical staffs, and especially for medical doctors and specialists. Currently in Indonesia, the density is 6.7 doctors to 10,000 population, which is still under the average of density in Asia, which we learn reach about 12 doctors per 10,000 population. And especially in outside Java region, because Java is the most densely populated areas, we see that shortage of doctors and medical specialists are more visible in outside Java. And of course, the maldistribution between urban and rural areas also still happening. In total, we have more than 200,000 doctors and medical specialists based on the registration data that available at the Indonesian Medical Council. And just like Thailand, we are currently working on to improve the National Health Workforce account to integrate between the registration system at the council with the registration system, with the information system at the Ministry of Health in order to have a better database of health workers. So far, I did not hear from 4 speakers about the dual practice, maybe not implemented in 4 countries present today. But in Indonesia, by law, medical doctors and also specialists are allowed to practice maximum at 3 different places. So it is very common for medical doctors and specialists who are employed at the government health facilities to have private practice or practicing at private health facilities. Somehow there is a discussion going on currently about monoloyalty of medical doctors with some interventions, including maybe provide some special incentive to keep them working at only one place, but it's still a discussion about this going on. But by law, it is still allowed. And to improve availability of health workers, the government of Indonesia implemented some policies, including deployment of fresh graduate medical doctors. So they undergo intensive program and deployed in the hospitals and also community health centers. And we also have a special assignment program to deploy some health workers based on the standard of the health facilities, especially for remote locations. And the government the central government provide the financial incentive, and usually the local government also provide additional incentive based on their financial capacity. And also we provide them some attractive intervention like opportunity to be recruited as civil servants, and also awards for scholarship for taking postgraduate study for health personnel, health workers, and also for doctors to take specialist training. I think it is also similar to Thailand, Japan, Bhutan, and also Lao PDR that Indonesia also provided some scholarship for students from the remote locations with the expectation that they will return to their rural areas to serve after graduation. And for the medical specialist training, we also provided some scholarship between 2008 and 2021. nearly 9,000 of medical doctors already received scholarship to be medical specialists in from some universities, because we still have limited capacity to produce medical specialists to this day. And for the improvement of the density of health workers, we are currently working on improving the National Health Workforce Account, so that maybe in the WHO, our number is still very low, but if we consider the number based on the registration at the Health Workforce Council, actually the number already exceeds the minimum threshold that reported by the WHO. That's for my comment, Dr. Viraj, and thank you very much for giving me this opportunity. Thank you.
Thank you. Thank you very much for your comment across 4 countries, as well as providing Indonesian context, and also dual practice is allowed at most 3 sites. I now invite Dr. Ibadat Diron, Regional Advisor HRH, Department of USC Health System and Life Cost, Regional Office of the WHO in Southeast Asia. Ibadat, you have the floor, sir.
Thank you, Dr. Viraj. Thank you, Dr. Anna, country panelists, and organizers. First, really congratulations to all the presenters, including Dr. Anna, because you've given us very clear examples of successful government measures, its implementation and monitoring, evidence-based monitoring. So this came through across all the presentations. I think in my brief intervention today, I really want to just point how important this discussion is in really this very historic moment that we sit in today. For the regional office, the last few weeks have been spent, the last few months have been really focused on developing a regional primary healthcare strategy. As part of this, I went through some old speeches by Dr. Mahler, and I just want to quote a few sentences as he introduced the Alma-Ata Declaration to the World Health Assembly. He introduced the declaration and he challenged the member states, and he asked them, are you ready to introduce the reforms required to ensure the availability of relevant human resources sufficient to cover the whole country with primary health care within the next 2 decades? Are you ready to introduce radical changes in the existing healthcare delivery system so it properly supports primary health care as the overriding health priority? And linked to what Dr. Suwit was also saying, he said, are you ready to fight the political and technical battles required to overcome any social and economic obstacles and professional resistance to the universal introduction of primary healthcare? So this was almost 50 years ago today. So it's a reminder really that after COVID, we are coming back to many of these same issues. The region as a whole has the highest rates of extreme poverty in the world, the highest rates of out-of-pocket expenditure on health, the lowest public spending on health, and COVID has really had a very devastating social and economic impact. It has disrupted health services, and the World Bank estimates that the majority of people pushed into extreme poverty in the world reside in this region. So it was based on these points that the ministers of health in the Sierra region really highlighted the need to orient health systems towards primary health care, both for equity and efficiency. And fundamentally, the discussion that has been organized PMAC today is really fundamental to this vision that is being discussed at the regional level, because it is this discussion around having the doctors, the health workers in our rural, remote areas, in the poorly staffed urban areas, that's going to be fundamental on this. On a positive note, I think as we've heard across many of the colleagues, the numbers of health workers in the region is increasing. At the same time, the distribution is really a very difficult issue to tackle. I will give you just one illustration. This is in Bangladesh, 3/4 of the Ministry of Health doctors and nurses are at the urban and in tertiary centers. Most of the education is in the capital city, Dhaka. And really, the periphery is being staffed by medical assistants and auxiliary nurses and midwives. And this is prominent across many of the countries of the region. It is the primary and the secondary district system that is competing with resources with the tertiary setting. So even in the Ministry of Health system, it's a big challenge. When we even speak to the numbers who are at the rural area, we see a significant challenge in the competence. So a number of studies have also shown that the health workers who are available in the rural areas, the quality of care is quite poor, and this is irrespective of qualification. The challenge of health workforce data is prominent across all countries of the region. And at the same time, while more and more is during all of this, more and more is being asked of the health workers who are in these rural areas. So I think we've all discussed the need to integrate NCDs into our systems, health emergencies, climate change, and wellness as well. So it's a really an important moment, and COVID in particular has made this a very important moment where both the clinical skills and the public health skills must be present in these communities for not just for our economic as much as our social well-being. The good news is, I think, as we already heard, that all of these reforms are heading us in the right direction. In the region, even prior to the pandemic, we could see that the governments were increasingly engaged in regulatory reforms to enable the distribution of health workers. Much like we heard in Japan and I think it was in Thailand and Laos. In India and Nepal, they had the regulatory reforms, which has again mandated compulsory service. It has capped how many schools can be in urban areas, and it's trying to make sure there's linkage between medical colleges and district hospitals. In India, actually, the last few years have seen the biggest ever increase in MBBS seats, in government MBBS seats, where government can play a role in their distribution. This has reversed 3 decades of declining seats in government and increasing seats in the private education system. A number of the countries have also tried to regulate the prices in private colleges and mandated spaces in private colleges to students from rural, remote areas. So this is an important initiative. These are all important initiatives. And at this moment, it's really, I think, as Dr. Viroj keeps saying, it's very fundamental that we start fully counting the PHC workforce as part of teams and look across the continuity of the district health system. And this came across very nicely in the discussions, both in Thailand and Bhutan, and the need for these care coordination teams, that if we have less people, can we get more efficient by linking up teams across different levels of care, and with digital technology, perhaps that there's more opportunity. And I think the Bhutan idea of progressive deployment is also really an interesting one in this regard. And finally, I think what comes across so clearly from some of the presentations, and especially the presentation in Japan, is for all of this to function, we really need the health workforce data to begin with. In a number of countries in the region, it became clear that there was a lack of knowledge of even the number of medical doctors in the public sector, let alone the private sector. And a number of countries are using now data from vaccination data to try to build up their database on the active health workforce. The real opportunity really is to link the data from the health facilities with data from the councils. And so it's really the example provided by Thailand on using an electronic platform for data sharing is really fundamental and can be a very useful tool in the region as we look at both policy and then quality and performance issues. But I'll stop there and really want to congratulate the panelists on this real breadth and depth of work that is happening in these countries. Thank you.
Thank you, Dr. Ebalat. I have just attended the launch and was one of panel discussion with Suker and Joe Cutsin on the global health expenditure of report. 2021. And we talk a lot about PSC expenditure based on OECD System of Health Account 2011. Country should have that capacity to estimate how much we spent at PSC, as well as headcount using health workforce account to monitor the number of PSC health workforce, because both spending and as well as health workforce and the service standard, as Bhutan colleague has described from his country experience, are so important interlinked jigsaw to make primary healthcare as a foundation for USC. And now invite Professor Dr. James Button, the adjunct professor from University of Technology, Sydney, Australia. He is also editor-in-chief of HRH. You have the floor, Jim.
Many thanks, Firoj, and I very much appreciate the opportunity to contribute to the meeting today on such an important issue. I'm actually using just 2 PowerPoint slides, and I will make sure that I keep to my allocated 5 minutes. I also had the benefit of seeing in advance the main session PowerPoint slides, so I had the opportunity to consider and reflect and create a couple of slides. I'm very appreciative of the invite. It's very good to be back with friends and colleagues in Thailand and elsewhere in Southeast Asia. And the 2 slides that I'm going to present, the first is just to reflect on the different framings and typologies that we can look at when considering how to improve future distribution of healthcare workforce. And then just on a second slide, I'm just going to really reflect back on what I think are some of the key messages that have come through from the 4 main presentations that we've heard so far. So this is a very busy slide. I'm not intending to go through it in detail, but I've put it up for 2 reasons. The first is this slide summarizes some of the key systematic reviews that have focused on health workforce distribution, retention, or recruitment and retention as their primary objective. And perhaps just to call your attention to the 3rd column, which is WHO 2010/2021. This essentially is the original evidence-based recommendations that WHO published on recruitment or retention in remote and rural areas, and the update in 2021, earlier this year. The evidence base that they identified and reported on, they structured the typology in terms of 4 potential areas of intervention to improve recruitment and retention. That was education, regulation, financial incentives, and professional and peer support. And if you just briefly look at how the other systematic reviews that have been published in the last 12 years or so have structured their findings, you can see there's a lot of commonality, a recognition that there are a range of different areas that policymakers must consider when working through the options on where to focus their efforts on improving distribution or retention. The second reason I put this slide up is just to make the point that distribution, retention, recruitment and retention quite often get used interchangeably in this sphere, but we should be very clear about what we mean when we use those phrases. So recruitment is about getting people where you want them. Retention is about keeping them where you want them to be. And distribution is more about looking at the allocative mechanisms and efficiencies within the system to try and ensure that we are matching numbers and skills with demand. So that's about allocation, access, etc. So an evidence base that has grown significantly over the last 10 or 12 years. And the 4 presentations that we've heard so far today add to that evidence base because we have new information, more country case studies, which is very helpful to build on. The second slide that I said I'd use is very much just my reflections on what I've read and heard in terms of the presentations today. Just 5 points. Number one, and I think the really important one, which also came through very strongly in the work I was involved in with Southeast Asia WHO region last year on looking at improving retention in remote areas. That's a recognition that there's no single solution to this challenge. We need to look at coordinated policy interventions that may need to be sustained over a period of time. So that's bundles of interventions. And the speakers we've heard so far, they were all in essence making that point. There's no single solution. You need to look across the different areas of potential intervention. The second point really that came through to me very strongly is that this is policy aimed at the moving target. Things change within health systems, things change within broader society and political and cultural changes. And we need to be looking at an approach which identifies what appears to be most effective, but then evaluates it. And when necessary, adapts and changes what we're doing as the circumstances themselves change. So there's a message there about evaluate, adapt, move forward. Third point, very much the case that we need to look at multi-stakeholder engagement. We need to know what the workers themselves regard as priorities and what will motivate them. We need to be clear about what the local community priorities are, where they're going to be working. So this is very much about multi-stakeholder engagement when identifying and developing the most effective interventions. My fourth point really is it's not just about education, but education is at the core of the solutions. That's recruiting students from the local areas that we want them to serve in, ensuring that training and rotation during undergraduate education gives them a lot of experience in those areas. And as much as possible, emphasizing primary care, general practice, rather than super specialization, because we need to be looking at getting the best first access points within the healthcare system, rather than over-relying on specialist secondary or third or tertiary care. A final point, we're focusing on the workforce, but this is not just a workforce problem, and it can't just be solved by looking at the workforce itself. We need to also consider service redesign or relocation. The pandemic has reinforced and revealed huge opportunities in the use of telehealth and digital support. That's in the provision of care, but also in the provision of ongoing training and education for workers. And we also need to be thinking about, in some geographies, mobile teams who might not be fixed in a locality. So that's a very quick summary of what I've heard. At various times, I've had the pleasure of working in Thailand, Laos, PDR, Bhutan, and Japan. So I'm very pleased to re-engage with these countries in this session and been very impressed by the knowledge that's being circulated in terms of these new case studies. Thanks very much for your attention. I look forward to having Q&A also. Thank you.
Thank you, Professor James Buchan. I now invite Dr. Panarat Wissawa Appanimit from Secretariat of AAAH, and she is the instructor in Bharamlochanok College of Public Health, Bangkok. You have the floor, Panarat.
Yes, thank you, Dr. Vinod, and everyone, and the project of policy that allowed AAAH to join in this project. So I'm really impressed that all 4 countries that have improved your rural retention and maldistributions of, even though it's still challenges, but it's improved. So there are some points that I would like to comment. So we see that the country used the compulsory service. However, the compulsory service is a short term for rural retention. Based on my experience in nursing profession, we see that after complete the compulsory service, some of the nurses or some of the doctor, they move from the rural area to urban or to another area. So the compulsory service is like the short term. So we have to be careful about the short term intervention, but of course it's still okay. And we found that for recommendation for the WHO is still conditioning and low evidence in this intervention. But I agree with Professor James that we have to use the bundles. But however, based on the COVID experience, we know that health is a matter of that person. How we improve the health of the people. Do we really need the doctors or healthcare profession in all the health need? So we have to be careful thinking for that. We cannot increase the number of the doctor, but we have to think about other healthcare team and work as a team. As you see that from the COVID-19 is a very good example for us that we want to finish the vaccine for inject the vaccine COVID-19. It cannot only the doctor that can work on that. So it have many people involved. So integration and seamless of the health system is important. And we have to welcome others to be our team as a primary healthcare worker, such as in Thailand, we have village health volunteer, or in other countries that we have. So, but of course, the rural physicians may no need specialists, but how we balance specialists and general practitioner or family doctor, or in Japan we call internal medicine. I think this is a very important issue as well. As I'm very impressed that for the registry of Japan, that you can update your registry and use the quota for specialists and general practitioner. That is very good, and I think that is a promote for the rural retention in the future, because somehow we have more specialists. So as we say that the health registry is very important. As we say that in Thailand, we try very hard to improve our health registry, but of course still have many involved stakeholders that involved in the HRH in our country. So that's why we have to make a collaboration. We have to work with them, and we think big, but we start small. And Dr. Thinakon present that we are going to do the pilot project with some council first. That's very important. So the quality of the health workforce, especially in rural retention, is important. This is the health education play important roles as well. I really admire that Lao PDR try to do accreditation and license and registration. So that is very important, and including Bhutan that try to improve this as well. So IPE or interprofessional health education is one of the intervention that it should start and it should try, because they know each other and they know scope of practice, and that it can expand the scope of practice when we have the changing health needs to respond. So I think that is very important, and we have to be careful about the hidden curriculum, because sometimes because of hidden curriculum that is make the medical student want to be the specialist more. So the continuous professional development is still very important, including in the rural retention. So for the based on experience of COVID-19, so we have to change to be online. So I think accreditation and quality of education is very important. One important part I want to leave is like the new generation is the challenges. So we found that especially in nursing, sometimes they don't want to be a civil servant anymore. So if we think that about the government position only, so that might not be the answer for the new generation of the health professional. So thank you very much for giving me a chance for comment.
Thank you very much, Dr. Panarat. I have one question to one of you on task shifting. A question from our Indian colleague said, asked about why we have to fill the gaps of doctors and nurses in rural area as well as specialists. What is the role of non-personal to fill the gaps of service capacity in primary healthcare? Namely, in India, they have AAAH, etc. Anyone to respond to this question from the floor? And then we go to the closing. Dr. Panarat or Dr. Jim Bakkan?
Yes, so I think the health volunteer in Thailand is very important. And we accept that they are the backbone of the health system. And during the COVID-19 as well. And now we extend just not the health volunteer. In the Thailand health volunteer, they take care of every health problem, just not specific health problem. So they take care of everything and they take care of 10 to 15 households. So that is quite good number. But even though like that, we still want to improve the family caregiver. We provide the training and want them to be able to take care of their families. And I think in the COVID-19 period, that is very, we can see that their role is very important. And I think that is one thing that we think about and we provide that training as well. Yeah.
Thank you very much. I now invite Professor Jim Bakkan with the floor.
Yeah, I think that is a critical question in all health systems. And my immediate response is that we need to be looking at task sharing across teams, and the focus should be on team effectiveness rather than looking at individual components within the team. And that also requires quite a broad definition of what we mean by workforce, and that should include volunteers, local community health workers. The underlying issue must be good coordination across those different individuals who are parts of the team.
Thank you very much for your explanation. In the interest of time, I like to invite the closing session by Dr. Achida, Director of Human Development Department Health Group from JICA. You have the floor, sir.
Okay, thank you, Dr. Biloch. Okay, so first of all, I'd like to express special thanks to the speakers who shared their country experiences. And also thank you very much for discussants from ministries, universities, and international agencies for sharing your deep insight. And also I'd like to express thank you for Dr. Sweet opening the meetings by highlighting not only the geographical disparities, but also the importance of the existence gap in many aspects in human resources, health workforce. And also thank you very much for Dr. Biloch, who chaired and facilitated this webinar, always guiding us with fair and intellectual viewpoint lined by your rich experience and wisdom. So I'm pleased to be with you today for this valuable and informative side meeting, focusing deeply on exchanging experience and view regarding health workforce. It's quite unique meeting because focusing on very specific issues of health workforce studies registries or activities figuring out the allocation of health workforce. So in this meeting, we learned a lot from the country experience and the country's effort of the Thailand, Laos, PDO, Bhutan, and Japan. And also we could enrich our understanding from the variable comments from the professionals from different organizations. So today I personally realized again that the challenge for health workforce is the essential things for attaining universal health coverage, and human resources issues requires continuous actions from long-term perspective. The registry is not only useful tool to solve every challenge of health workforce, but it is entry point to know true figure and visualize what happens in distribution of health workforce in the country. So needless to say, the utilization itself of the registries is important, but through the meeting, I could notice the importance of building consensus with various stakeholders, setting proper standards from the situations, and quality assurance such as licensing, and private sector's involvement in preparation of unexpected situations, and many things, so on. So I hope every participant got something to think about the importance of health workforce and a tip of solution to management of human resources through this meeting. So finally, allow me to express thank you very much for co-organizers of this site meeting, especially for GLO+UHC Phase 2 colleagues, and also PMAC Secretariat for coordinating every process of this international conference in spite of COVID-19 situation. And finally, thank you very much for the participants of all of your participation and giving us your time. See you in next occasion. Thank you.
Thank you, Dr. Achida. And thank you everyone, every panelist and speaker from four countries and the 4 commentators. Have a good evening. Thank you so much on behalf of the AAAH Secretariat and GLO+UHC. Thank you. Bye-bye.
Thank you. Goodbye.
Okay, bye-bye.
Thank you very much.
Thank you very much.
Thank you, everyone.
Bye.
Thank you, everybody. Good night. Good night.
Good night.
Thank you very much.